All right. We're going to go ahead and get started. It is 5:03, and just to respect everybody's time, I'll do that. And then we'll let people fly in as they do. Just so everybody knows, this is being recorded. We want to thank you guys for coming to the virtual educational seminar titled How Controlled versus Non-Controlled Ratios Can Impact the Patient's Access to Care. This seminar is being sponsored by Advanced RX in partnership with SureMed Compliance. SureMed Compliance is a mission-based organization with the goal of improving access to appropriate pain management care. And they accomplish this through the use of their digital health platform, Perspectives in Care, which helps healthcare providers remain compliant when prescribing controlled substances. Advanced RX is the nation's leader in pharmacy management services. Their proprietary dispensing software, Easy Dispense, enables efficient, accurate in-clinic dispensing and billing, and their mail order pharmacy allows for fast, discreet shipping of all medications. Advanced RX is a proud mission partner for SureMed Compliance. I see we have a few more people coming in. Thank you very much. And today we did tell you the title of this, but we are going to get into a lot of other things as well when it comes to pharmacy management services. We have two of the best in the industry. Many of you probably already know Dr. Mark Garofoli, aka the Pain Guy. He has been on been in a few of our seminars before, also speaks, is a TEDx speaker, been talked all over the country and all over the world actually on pharmacy management, being a pharmacist and what that means, specifically in the pain space. So Mark Garofoli is a Pitt PharmD graduate, Strayer MBA graduate, board certified geriatric pharmacist, board certified pain educator, and certified tobacco treatment specialist. His past positions include being a pharmacist leader with CVS Health, Humana, and the West Virginia Safe and Effective Management of Pain program, along with coordinating the West Virginia SEMP guideline panel. Today, he is at West Virginia University School of Pharmacy faculty, West Virginia University School of Pharmacy Director of Experiential Learning, West Virginia School of Medicine Pain Fellowship faculty, and a West Virginia University Medicine Pain and Addiction pharmacist. Mark Pain Guy Garofoli has been a 2021 TEDx talker, CDC grant reviewer, civil criminal expert witness, seasoned CE developer and presenter, host of the Pain Pod Pharmacy Podcast Network, editor of the Pain Press, and publishes painguy.us website. So please help us welcome Dr. Mark Garofoli here. Our next speaker is Robert Bird. Robert Bird, PharmD, is an accomplished healthcare operations leader with over a decade of experience in clinical therapeutics, pharmaceutical operations, and medication management. He brings expertise in multi-state pharmacy licensing, EGMP, FDA compliance, pharmaceutical supply chain management, and formulary design. Robert has a proven track record of driving evidence-based decision-making, optimizing patient care outcomes, and reducing pharmaceutical costs. Throughout his career, Robert has successfully led teams across a variety of sectors, including pharmacy operations, wholesale distribution, manufacturing, and clinical pharmacy practice. His work spans both operational and clinical domains, giving him a unique ability to integrate strategy with day-to-day execution. Please help us welcome Dr. Robert Bird. And thank you. I see we have some people still coming in. For those that are coming in, we are going to mute you when you come in, if that's okay. Just know that if you are, we are going to open it up to questions too. So let's talk a little bit about the format. First and foremost, we are being recorded as well, because we will be using this later on. So what we wanted to do with this format is make it a little bit more conversational. Typically, when you come into these seminars like this or these webinars, you've got people talking at you, presenting a deck. What we thought would be more helpful is to have a real open discussion about some of the challenges that are happening in pharmacy. And some of these are very unique and some of these are very new. So I think you're going to hopefully get a lot of really good insight into what's not only happening right now, but what's coming down the pipe as well, given the state of the industry. And so I'm going to moderate this. I'm also going to be the one that's sort of asking questions. And the idea here is just to let everybody kind of talk freely, but speakers talk freely about these issues. We'll stop in between certain questions as well. If you do raise your hand because you have a question, just hit that little emoji there on the bottom that'll allow you to raise your hand, and I will call on you and take you off mute. Okay. So real quick, Mark and Robert, before we get into some of the questions that I have for you, would you mind kind of giving us just a little bit of background into what a typical day looks like? Mark, I know you have been doing this for decades now, and you've got a lot of experience, and that role's changed over the years. Tell me what it looks like today.
Oh, the average day. I got a feeling that Robert and I might have some similar things because we were chatting earlier, even on the home front, on families with young ones and whatnot. So, um, life is balance. There's certainly no average day, but the general components, and you want to put. It's like getting on an airplane. Put your mask on first, if at all possible, and trying to keep it real and consistent. Do a little workout, do a little something, get yourself going, get your mind going, get your body going. To start a day, at least that's how I try and trick myself because I figure if I try to work out at night, I might be a little bit more cognizant. Let's get in there before the brain starts firing. So, and then of course supplement with, whether it's an espresso or a coffee or dare we say both. Um, Moderation, the dose matters, of course. And then get things kicking, whether it's going right to the School of Pharmacy with, teaching student pharmacists or other healthcare professionals, or if it's going to the pain clinic, basically, patient care, it's education 101, teaching the patients along the way, hopefully helping folks along the way. Flip flop with that throughout the day, get a consult here or there, try and help out on the pharmacy side, and then learn from the other professions along the way. I swear in the beginning when I used to watch physical exams, I thought it was closer to voodoo, because that's just not what we do in pharmacy. But um, it's a two-way street. Could teach, but could also learn there as well. Sooner or later, the sun's getting closer to going down, and that's when youth sports will kick in. Typically, baseball in the Garofoli household. Yeah, that'll probably lead to some injuries here or there. So pain is still out there. You can help people. Um, and then, around about, let's say about 2 a.m., you try to go to bed again, right? Because if you're going to do those presentations you talked about, John, I loved it when you were like, oh, there's slides and you yap, you yap. I am convinced that since we made it to the moon and we made the internet, the next thing coming is figuring out how to do a presentation, even beyond TED, just something bigger. So I'm really appreciative to be here tonight with
Yeah.
Robert, with yourself for this conversation style. So that's the ins and outs of an average day, I guess we'll say.
Thank you, Mark. I appreciate that. And Robert, back to you here. I know you work in a little bit of a different sort of a setting. Mark's a lot more focused on teaching at the university level there, as well as his clinical work that he does at the Pain Center. But also, you have a kind of a different venue where you perform pharmacy management. We go ahead and talk a little bit about what that is.
Yeah, yeah. So it's the day's definitely similar in some aspects and then different in others. So we have a mail order pharmacy here licensed in 46 states, and we also have a wholesale and repackaging operation. So it ranges and day to day, typically I'll start out just going through emails and setting the goals for the day, big items that need to get knocked off, and then from there, it could be looking over purchasing agreements. It could be contracts with payers. It could be compliance related issues for state licensures we're working on and or have. And issues, not to say there are issues with compliance, but more so ensuring that we have the best compliance. And then from there, it truly ranges. It could be on our repackaging side here. It could be working with the team or looking to source a new equipment. On the pharmacy side, I could be working on developing compounds for a partnership with another company or to meet a specific patient and provider need. We do compound as well. So that definitely it kind of flip flops throughout the day.
Thank you, Robert. I appreciate that.
Absolutely.
Um, So really one of the main reasons we're having this entire discussion is because there's been a number of changes, as both of you know, when it comes to the pharmacy, especially around controlled substance prescribing. That's a hot issue, obviously, with the opioid epidemic, which has been raging on. What we know about the opioid epidemic is it's changed significantly from really being mostly prescription opioids that were, implicated in these overdoses to less than 10% of all overdoses, even involving a prescription opioid at this point, and most of it coming from illegally manufactured fentanyl now. Some would argue, and I think rightly so, that that has to do with a lack of access to proper care. I think there's been a cooling effect. I think that's been well demonstrated because of the regulation in the space. But whatever their cause is, we know that patients are having less access to the medications that they're being prescribed. And we know that there's several reasons why it's hindered, but I guess maybe you can share a bit about what you're seeing, both of you, as it pertains to the issue. You both get prescriptions for controlled substances from time to time. What are the challenges? Or let me just say, in real world setting, what are you seeing? Robert, let me start with you. What are you seeing when it comes to those challenges and patients not being able to get those medications? What's that look like?
Absolutely. So it's multifaceted. I think there's distribution issues, which is one side of it, to where, you know, can we obtain the control medications that we need to supply for the patients that need the medication? And then from that point, it's, you know, can we fill it? If we have it and we can fill it, well, ratios come into play, other things come into play. Is the patient new to our pharmacy? Because a lot of patients that are trying to get a pain prescription, if you take that to a pharmacy they haven't been to, they're not going to fill it. It's not going to happen. You know, so maintaining that and ensuring that, you know, our balance for the patients that we take in allows us to service every patient that we have. And those are the two big things that I see: the distribution, and then also just ensuring that, you know, because if we can't get it, our suppliers are going to limit us, then we can't serve the patients that truly need it.
Yeah. And are you seeing some big challenges, Robert, at the pharmacy level there?
Yes.
Of course you are. Okay.
Every day. I mean, it's no matter what supplier you're purchasing from, or no matter what, you know, new patients, if they're in pain, they're going to need a pain medication. And a lot of times that's, you know, that's going to be a control medication. And that's definitely a huge limitation in these days.
Got it. Thank you, Robert. Mark, you mind weighing in on that? What you're seeing?
I really appreciate how granular Robert was able to go there too. I mean, you know, when your boots on the ground and you're experiencing these things, it's asking the easiest questions ever, right? But you know, even in the bigger picture, we seem to be in this pendulum always with everything. We happen to be talking about pain and controlled substances today, but you know, I'm no philosopher here, but like we do this in society all the time. It's one extreme to the other, and you know, this is meant to be more conversational. So since we don't have slide decks, we can go on that. A couple months ago, had this scenario pop up. Okay, I'm an aging guy. So of course these social medias are going to target me for various things like ugly Christmas sweaters and Viagra. Um, so I got both of those ads. And I informed my wife because I was like, oh, I know what I'm going to do with this. And I want her to know. And so I clicked on, we're talking about the Viagra now, not the ugly Christmas sweaters.
Got it.
Clicked on it, and I'm like, I'm gonna get more ads, right? And by golly, every one of them is buck a pill, click here, get it tomorrow, maybe the day after, right? And I started thinking, I'm like, man, these lifestyle medications, substances, whatever, we make it so easy. Well, maybe not we, but someone makes it so easy. And then I thought to self, wow, like a year and a half ago, I needed a refill on a seasonal allergy nose spray. Okay, we're not talking controlled substance here. This skews the ratio the other way. And I got held hostage for the thing. Oh, I needed an appointment, and then I was like, oh, how about telehealth? Because you know, and then I had the wild card in my pocket. I'm like, I know it's going OTC in 3 months. Let's just see how we treat patients. In my own system, by the way. It was so
Gotcha.
like, and I'm like, again, I could click a button and get whatever I want, and pretty sure they'd offer me something for hair or lack thereof if I did. But the other stuff, we lock it up like no other, and it that pendulum, the extremes, is really, you know, where it's at there. But the interesting thing in healthcare, in pharmacy particularly, is there's a lot of legit reasonings for those consternations along the way. You know, we've been navigating John, you brought up the whole opioid epidemic, opioid crisis, whatever label we use. It you know, long time now has swung over to the cartel side. I mean, that's even the headlines have caught up to that. Yet we're still getting the kidney punches in healthcare. And we do need our checks and balances. We need to go on the right road, of course. But you know, let's at least pave the road. Let's not, you know, use the Flintstones mobile to get down the darn thing for our patients. It's tough.
Yeah. Yeah, it's been, you know, we see it more and more. We know that, you know, aggregate production of opioids has been limited again by the DEA. I think 7% this year. I think it was maybe 2 or 3% the year before, and we had major shortages then. You know, I think we had a few pharmacists that signed up for this as well that are on this call right now. So I think it's interesting to note that most people don't realize that the pharmacist that dispenses the controlled medication also has a 50% corresponding responsibility for that prescription under the Controlled Substance Act, meaning that it's not just the prescriber that has the risk. I've always thought about this, that it seems a bit unfair, right? Given that the pharmacy has significantly less data to review to help them inform whether the prescription is being written for a legitimate medical purpose or not, right? I mean, you have very limited pieces of data, and yet you're being now held to the same standard, 50%, right? Same standard as a physician with the limited data. How do you make those decisions on whether to dispense or not? And what data is the most meaningful to you? And it may be different given, Mark, you're at a brick and mortar kind of location where you're seeing these patients. Robert, you're kind of blind a lot of times, right? I mean, you just get in a prescription sometimes. So, Mark, let me start with you in the brick and mortar scenario. How do you make those decisions on whether to dispense or not, based on the fact that you don't have a whole lot of data to look at?
Yeah, I'd even want to elaborate on that first part a little bit more, even too. Part of it all is typically insurance billing. I'm not going to use any of these words like, 3 letters or anything like that, but like PBM, just to clarify. The others, I guess. But anyways, like when a patient comes to a pharmacy, presents their insurance card, like the ruckus begins. There's no QR code to scan. There's not even the magnetic strip to swipe. Forget about your smartwatch. We're still in 1973 typing in numbers and guessing if there's a 3 or a 5 on the end based on what happened 17 patients ago. We haven't even gotten to do we have the thing in stock yet. Like this is just creating a profile. That's what we're up against. Like it's my family's all pharmacists. My father always talks about, he does lots of presentations too. He always talks about you go to like Sam's Club and get gas with a QR code on your phone, yet I can't get medication to save my life with something even easier. So there's that. And then it's okay, now let's jump over to that was really in the consternation for the patient. What about, okay, now back to the clinician side, because we're right there with everybody. The getting the information, you mentioned that corresponding legal responsibility, the most basic thing on every state's law exam for pharmacists. We are the only healthcare profession with a law exam. Always interesting. I feel like that should be a question on said law exam. But anyways, never will be. Corresponding legal responsibility. It's basically that diagnosis and scope of practice. That's actually really low-hanging fruit. I mean, that's actually like the rotten fruit on the ground. I mean, like,
Right.
okay, are you not a pediatrist treating a neck? Is it pain? I mean, at some point, actually, I think it was John. I won't blame Robert, sorry, but it said something about ICD-10 codes. I feel like we should ask, hey, what's everybody's favorite ICD-10 code to see? 89.4, pain. Well, like, there's actually another one that's just chronic opioid use. Well, like, is that a condition or is that a situation?
Right.
Like it, ay. So, and again, I'm not in conversation here. I'm not trying to downplay this major responsibility for all prescribers and dispensers across our country. But when you look at it like that, it's pretty low hanging fruit. But then we do have to go further into the things of flags. I'm not going to go with the color yet, but flags and other things. Getting to know, actually having a professional relationship and conversation minimally to know someone, which takes time, right? So.
That's great, Mark. Thank you. Robert, you're coming from a completely different angle here. You don't have the luxury of actually having a face-to-face with the patient. You kind of just get something sent over, and oftentimes that little, sometimes we would say sort of arbitrary ICD-10 code that's on there is not even on that prescription either. So what data is important to you, knowing that you have this? And by the way, one of the reasons I'm framing the question this way is because I think it's important for their listeners to understand when you have a lack of data, you don't get to make very good informed decisions. And what that means is you've got to be real conservative, right? If you think about what's happening within the entire supply chain, it's just a lack of data within, whether it's the wholesaler, the pharmacist, and even, again, if it doesn't come from the physician to begin with, then what are the chances the wholesaler and the pharmacist are going to have that data, right? Very, very rare. And in light of that sort of scenario, people have to just be super conservative, right? And they don't want to be. but it's contributing to what we see is this lack of access to care for patients because the data is not there. So, Robert, I didn't mean to speak over you, but what
No,
does it look like for you? What pieces of data do you look for, and how challenging is it that you don't have it?
I mean, we're going in it blind. I mean, you know, that 50% responsibility that we have. I mean, I'm standing behind this computer and I have an electronic prescription in front of me. I don't have a patient. I don't have a provider. I have that, and I might have a medication profile. You know, there might be some things on there, some notes, some you know, diagnoses that we've had from probably from the ICD-10s we've input, or from asking the patient. But beyond that, we're totally blind. We check the CSMD so we can see the last time medication was dispensed with every patient. We always do that in every dispense, but that's not really giving you the full picture, right? That's not telling you anything beyond that. So we really are, we're having to blanket those conversations and those decisions to be very, very careful with what is dispensed, because we don't see it. We don't see anything else. I can get an ICD-10 and say, okay, hey, this doctor has a valid DEA, is a valid medical practice. I wasn't there for the appointment. I didn't see anything that went on inside that examination room, but I know that this doctor has Surescripts and can send that prescription to me, and that the DEA is valid and the CSMD checks out. It's a tough decision, and a lot of times you really have to just be more so on the cautious side, unfortunately.
Yeah, and I think that's a fair point, and I think that's what's happening a lot of times at the pharmacy level is, you know, I think when you speak to doctors, they say, just fill the thing, right? You hear doctors, the rhetoric, which is, I don't know why the pharmacist isn't filling this thing, right? And yet the pharmacist, you don't have it. And so, you know, we're going to get into some ways where I think we can fix this, because I think you guys have some good ideas around that already. But it's good for, I think, the listeners to kind of hear just how difficult it is when they feel like pharmacy, there's already a stigma in the space, right? You're stigmatized the minute you walk into your doctor's office, whether you like it or not. You're stigmatized at the pharmacy now. You know, trying to eliminate that, because patients, you know, some patients desperately need these medications for quality of life. So I'm going to get into legitimate medical purpose now, because I think it's probably one of the most important phrases that you can possibly use. Interestingly enough, I was on the phone with a guy named Eli Stutzman. Eli Stutzman was the attorney who actually penned the Death with Dignity Act. He was the one that proceeded over, or pardon me, that was an attorney on that Oregon v. Gonzalez case that made its way all the way to the Supreme Court. I actually had a very good conversation with him today. And interestingly enough, just in time for this talk. And legitimate medical purpose is one of these things that is just so difficult for people to get their heads around, because it is the standard really by which the entire supply chain is held to, right? Whether you're the wholesaler, the pharmacist, or the physician. And really, up until recently, it was rare for pharmacists to even require evidence that that standard was being met. We always know that, yeah, they had a corresponding responsibility since 1970, maybe. However, we didn't see this, you know, tons of litigation and criminal prosecution of pharmacists when that standard wasn't really being met. Typically, a valid prescription, an ICD-10 code, again, here we go with that, you know, clearing any DEA red flags would suffice, right? But now, due to the recently settled multi-district litigation suit between the three major pharmacy retailers and the DOJ, and that, you know, that contains some of those, you know, 25, 27 pages of injunctive relief there, pharmacists across the country now are refusing to fill without first getting evidence that legitimate medical purpose is being met. Mark, you and I went down this path quite a bit on that task force that we did, really trying to understand those terms, and it's daunting. The changes that are coming to the pharmacy are daunting. The clearinghouse has not been set up yet, but from you know, what it looks like, it will be next year. And when that happens, there's going to be major changes. And so this is causing a huge logistical issue, which is, if the physician isn't meeting legitimate medical purpose, how in the world is the pharmacist going to get evidence of it? And if the pharmacist can't get that evidence, they can't fill the thing. Otherwise, the wholesalers are going to say, we're not shipping to you unless you have it. So it's just we can see the supply chain all of a sudden getting pretty disrupted because of this. So here's the question in all of this. What can physicians do to assist with helping ensure that the patient gets the medications they're being prescribed? So here's what I want to say is, Mark and Robert, you guys are dealing with physicians day in and day out. They're prescribing stuff. They want their patient to get it. sometimes you have to have these really candid, uncomfortable conversations and say, help me out a little bit. I can't do this without you doing this. What are some of those things? Robert, I want to start with you on this one because I know you and I have talked in great detail about it. What are things that doctors can do to make sure the patient gets it the first time so you don't have to worry about the callbacks and the faxes and all the other stuff?
Yeah. So, I think the big thing to make sure that the patient's getting the medication is, making sure for us, it's a lot about ratios. If we get just to control, it's hard for us to just dispense that if there's nothing else. What's first line therapy? Have they tried an NSAID? And at least documentation of that. Because if they have tried other non-control medications, then I want to know that they tried that before they're just throwing out a C2 or something else. Or that documentation is what we truly need. Sending the chart notes or stuff that you typically is not truly efficient for a practice to do. It's not feasible in every scenario. If I call and bug the office administrator and say, hey, I've got these patients that I know this doctor is prescribing them for all the right reasons, but I've got to do my due diligence and make sure, okay, well, can you send me, the chart notes from the last appointment? Can you, what all was checked? And surprisingly, even when you get that, sometimes it doesn't contain all the pieces that you want to see that they were checked. So I think having a tool or a way to increase the communication between the provider, the practice, the provider, and the pharmacy is critical to us ensuring that the patients get the medication that they need.
Yeah, Robert,
That's great. Thank you, Robert.
I'll devil's advocate you in a good way. I agree 120% because it takes that extra communication to get that information. And then there's this like chicken or the egg thing for, tit for tat. It's not who you gonna call, that's Ghostbusters. Who's gonna call? And then you look, okay, well, correspondingly responsive 50-50, both should call. Well, then both lines are busy. I've often challenged folks on the prescribing side, call yourself, literally call yourself, not your cell phone. That might not work either. And same thing, by the way, for our own, for, on the dispensing side, call yourself, try and get through. It's so hard. If it's even possible along the way. But those proactive conversations, the campfire kumbaya side, we got to have these things. Unless there's a mechanism that streamlines it, that just says, okay, like nobody can have the time to do the whole phone thing. This isn't saying you don't have the time for patient care. It's the follow-up to enable the patient care along the way. And that's, to me, that's one of the biggest things is, again, time, like just people in the time to be able to do that.
Well, there's not enough time for it. If you think of it from a retail perspective too, it's like you've got, looking outside at other pharmacies, we've got drive-throughs, we've got delivery drivers, we've got front end over-the-counter medications. We have all this going on, but yet we've got to take that extra time to call a practice and try to obtain this extra information and hope that, to your point, 100%, hope that they answer. And you don't have to leave a message and say, hey, well, whenever they call me back, we'll get that prescription ready for you. No, that's not acceptable. That's not how I would want my medication or anybody's medication to be handled. So opening those doors of communication are critical.
Yeah. Yeah. And I think, Robert, we will talk a little bit, I know, about our partnership with Advanced RX and what we're doing to try and solve that problem. So I'll tee that up in a minute. But real quick, I know we've got some people here on the call. I haven't seen anybody's hands go up, but I think it'd be a great time. I'm going to continue to ask some questions, but if you do have questions, please just raise your hand with your little hand emoji there, and we'll get to you. We want to make this as conversational as possible. Robert, you mentioned ratios a minute ago. This is probably one of the most, I would say, misunderstood challenges when it comes to pharmacy. I'll even agree that before I knew who Advanced RX was and before we met, I didn't fully understand it. And it took a former DEA guy and you and a couple other people trying to break it down for me to go, I did not realize this is such an issue. I didn't realize this is how they're actually making these decisions, and then thought to myself, well, how arbitrary is that? I mean, when you really think about what so much of the decision is being made by. So let me just say the title of this panel discussion is how controlled versus non-controlled prescription ratios can impact a patient's access to care. Where do these proposed ratios come from? And what does it mean to a physician who's trying to ensure that the patient gets the medications? Specifically, we're talking C2s primarily that they were prescribed. Robert, let me start with you just because I know we've had a lot of conversations. And Mark,
Yeah.
I'd love for you to weigh in as well.
Yeah, so I mean, it kind of it starts from the top. I mean, it's a very like you talk about, it's something that's an unspoken rule, right? If you have a supplier reach out, let's say it's one of the big three, and you have a supplier say, hey, we need to have a conversation about the controls that you're dispensing from your pharmacy, and say, okay, I know my patients, I know my providers, I know that every prescription is 100% written for legitimate medical reason. But what's your control ratio? They won't say that, but they're saying you're dispensing too many controls. And then it's just sorry, you're cut off.
So it's almost as if there's this sort of like this invisible standard they're not really telling you about, and they're just saying, hey, they're saying, hey, here's the line, here's what you need to do, which is legitimate medical purpose, and yet you're aiming for a mark, but the mark's over here. They're not even. This is what they're actually measuring.
It's always a moving target, and there isn't a clear cut answer to it as to what you need to hit to be in compliance. But you know what, you've gone a little bit more than you need to. Okay, well, maybe this is the patient population that's in the area where my pharmacy is, and maybe we're a big manufacturing area where people are more amped to get hurt and get injured. There's a lot of demographics that come into play too in terms of that, and having just a ratio, but more of an unsaid ratio that we need to meet makes it very difficult, because everything else we do in pharmacy is pretty clear cut. It's pretty okay. This is a law. This is a rule. Hey, we follow those. But now we have a very gray area that we have to make sure that we fall in between when we don't really know how we need to do that. And so we've had those conversations, because for me, it's over time, I've kind of figured out from being on both sides of it, what that looks like and what I need to do to maintain compliance for pharmacy and in the DEA's eyes and in the board's eyes, and to maintain compliance for a wholesale manufacturer in the DEA's and board's eyes. And that is all based on the ratios of non-controls to control medications.
That's incredible. Mark, you must probably you've seen the same exact thing. I mean, what are your thoughts on this ratio? I know the wholesalers are using AI now. They've got algorithms that they run, and it's a simple calculation, really. And if you think about what those inputs are, they have not been, very forthcoming with what those, what's in the algorithm, I should say. But we know that ratios play a big role in that, because again, there's very limited data that they have access to. So of course, in the lack, when you have a lack of data, you're going to go ahead and use the data that you have, and you're going to have to be super conservative, I guess, is what they're doing. What are your thoughts, Mark?
I cracked the algorithm. It's
You did it.
it's that picture that I don't even think it's a meme. I genuinely think it's a picture. It's Alan from The Hangover when he's doing the calculations for blackjack. It's that. It's clearly that. That's the algorithm. It's either that or the Matrix. But anyways, yeah, movie night. In all seriousness, though, there's two sides to every coin, even a Bitcoin. When you look at it through the eyes of what did the pill mills do? I think we're in a place where we could say words like pill mill, right? Well, they dispensed the ratio was not even a ratio. It was a digit. It's 100%, So, there's rhyme or reason to that. Pigs live, hogs die. But when you base an entire, say it's a society based off of the extremists, is that ever going to work out well? Again, in the big picture. What I always challenge folks are, okay, law is by definition objective. So if ratio is a thing, what's the number? And if the number can't be out there, it still doesn't DQ it. Because you mentioned the whole expert witness background things too. It's like, well, again, devil's advocate. Say you're looking at a pharmacy that for 3 years, 90% of everything coming out of it, thousands of prescriptions, is all controlled substances. I mean, does that warrant a little like, let's take a little look-see? Yeah. If it was 80, if it was 70, again, the number is negotiable there, but the concept is there. It's good intention, but being misapplied hour by hour, minute by minute. And the other, side of the coin too. We talked about the national opioid settlement. So you've got these cases that were brought forth, settling for $46 billion. That catches some eyes on folks to say, okay, action needs to be taken. So that all happens, and now they're, for I believe the way to word it would be presumably not having limits. Well, then okay, we'll have them. But now
Yeah.
we see them being put out, even, let's say something like buprenorphine. Yes, it's in the, opioid use disorder, opioid addiction realm, but it's also in the pain management realm too, microgram. They're all in the same ratio, kit and caboodle there. They're not necessarily, I hope milligrams would be within an algorithm, but we don't know. It's well intended, but that intention seems to have had its time. Now that the opioid crisis is close enough to completely on the illicit side. That's
Right. No, that makes a lot of sense. I think we're hopeful that maybe that cooler heads will prevail and somebody will look at this and say, and again, I think it's a lack of, at the end of the day, when you don't have data, you have to be conservative. You have to rely on the only piece of data you have. And oftentimes that's not really compelling. I mean, ratio, believe it or not, has absolutely nothing to do with the definition of legitimate medical purpose, which is by way the standard that they're trying to meet. It has nothing to do with it at all. And again, so here's the standard they're telling you, but over here is actually where's the target, right? That's the target that you need to be hitting. So let's talk about 3-to-1 ratio real quick, because I really want to get into something where I'd love for people to kind of get an idea of practically how are you even having that conversation, right? So when I hear 3-to-1 ratio, and I'll admit it, when I first heard it, I thought, wait, you have pharmacists telling doctors to start prescribing other stuff now? Like, whoa, why is a pharmacist telling a doctor they need more things? And you can see how counterintuitive that would be to an already exhausted healthcare system, right? So different entities all kind of figuring out what regulations they're going to have is causing issues with the other one, right? I mean, you can just see how the pie is going to get unequally divided in a lot of ways. How do you have the conversation with a physician that wants to get the C2 filled for the patient, does not want to get those phone calls back, doesn't have time to deal with it, but maybe isn't meeting that ratio? Robert, you have to be having these conversations daily.
I deal with that all the time. It's a very tough conversation because I think the biggest thing, like you said, is that I am no shape or form ever want a provider to think I'm trying to influence them or trying to say that they need to write another medication, another prescription. That is never ever the intent or the purpose. But what it is to let them know what standard we're being held to, and what I need, and what for me to be compliant and to be able to service patients, the ratios that I have to meet. Otherwise, I'm not going to be able to get medications. That's just the world that we're in right now. We're on that extreme side where this is what we have to do, and you can't. It's hard to go case by case because if you're dealing with lots of patients, how do you do that? Well, unfortunately, just like pharmacies are being blanketed, we have to blanket our patients, unfortunately, and otherwise we're not going to be compliant. And I think that's the hardest thing to do, is to have that conversation and say, hey, I know this patient. I know this patient is, comes here all the time, but I can't fill just this and one other medication for your patient because it's going to throw off my ratios.
And I have to say, at least, kudos to Advanced RX and to you for at least having those difficult conversations and being willing to try and adapt. Because what I hear from a lot of the pharmacists that I speak to, especially independents, they just say, I just don't even fill the C2. And I say, you don't? And they go, no, we don't fill it. And I say, well, that's not fair to the patient. They say, well, I'm not taking the risk. I just don't do it at all. As a matter of fact, just the pharmacist I was talking to the other day, they just said we refuse, we just don't even fill the C2s at all. They can bring us everything else, and we'll be happy to do that. So again, when we talk about access to care, well, the medication you're being prescribed, the therapies you're being prescribed is care, and patients
Yep.
definitely have hindered access to care because of some of the way that this is all shaping up in the pharmacy space. And what it seems like it's only getting worse. Mark, are you seeing the same exact thing on your end as far as like, I mean, do you have those difficult conversations? How do you, are you at the mindset of just going like, if I just don't see the right ratios, I don't feel for that provider? Or I know you're also in kind of in an enclosed healthcare system, so it may be a little bit of a different scenario.
Yeah, I'm unique, but it's but I could still draw on experiences and all that too. But I'd even want to go downstream from that a little bit. I think it's something because we're missing something here. So, to John, to what you said of the okay, when folks say no, okay, this first pharmacy says no, the second pharmacy says no, maybe the third, if not the fourth, finally says yes. The one that says yes is hopefully there to help people, keeping an open mind and whatnot, and seems to have figured out the wholesaler distributor side of things. But then think about their number, not even the ratio. We'll come back to that, but just the amount of controls is going to be higher relative to their peers, which is undoubtedly part of whatever algorithms, because you're going to compare to other pharmacies.
Right.
The math is set up just in a way that where I think this leads to is we need undercover boss, but we need undercover patient. We need folks that can make decisions in this country and in these companies, in both there, you know, entrepreneur and government and whatnot, to just take go get a prescription. Try and go get one. Because the day is going to come when we are all human. We are all going to be in pain sooner or later. I can tell you my experience I had when in my most horrific pain thing was with the kidney stone. And let me tell you, the healthcare system was not all that peachy to me at every single moment. And it wasn't even a heavy hitter script. It was up. But living that, it is eye-opening. And this, I'm talking as people, we do this. like um that's what I just wish could happen. It is for that more enlightenment because with like so many things in the world today, until it hits home for you, you don't really understand it. And we've got
Sure.
patients in pain that have been in pain for decades, and different prescribers, different dispensers, people trying to help them. And then what? All it takes is one no, and then like Robert said earlier, okay, now walk in somewhere and see how easy that's gonna be. Not the most compassionate thing. But again, online, click a button. You know.
Yeah.
Yep.
Get your ED meds, get your hair
Yeah.
meds, whatever it is. Yeah.
Yeah, but anything else, it's incredible. I was working with a provider last week, and the patient took me 4 days to help this provider find a pharmacy for this patient because a patient's getting turned down in their state, right and left. And it's for a legitimate medical purpose. I mean, I'm on the phone with the provider and their nurse daily, multiple times a day, texting and being like, okay, hey, I tried XYZ pharmacies. They were all no-goes. Even with another pharmacist calling and saying, hey, I've got this provider, this patient, they have a C2 script. That's it. That's all they have. They don't have any other non-controls with it. This is legitimate for legitimate purpose. Took nearly 5 days to find a pharmacy that was willing to accept that patient. And I don't think they would have if it wouldn't have been for another pharmacist calling. I don't think they would have. I think if that patient would have showed up, I don't think they would. And it's unfortunate.
And we know what the result of that is, right? We know the result of taking a patient who's been, chemically dependent on a controlled substance like an opioid for years
Oh, yeah.
sometimes, and just abruptly cutting them off because of access, right? We know what happens. If you've never experienced withdrawal symptoms then you may not understand just how terrible they are. But it'll take somebody who is a law-abiding citizen that would never ever think about cooking anything on a spoon and injecting it into their arm, and it'll make them go and look for getting anything they can get their hands on from friends and family. And of course, what are we encountering? We're encountering pills that look very similar to the pills that have been prescribed in the past. And the latest statistic that I just read was something like 3 out of every 4 illegally manufactured or counterfeit pills has enough fentanyl to kill the user. I mean, it's a
Yep.
death sentence for people who, again, would be normally law-abiding citizens, but now are, faced with these horrible side effects because of a system that is just continuing to break down. It feels like, and I think we've had an irrational fear. People look at SherMed a lot of times, our company, and say, "Oh, that's the anti-opioid company," and they couldn't be more wrong. I mean, we were just trying to help with the overdoses, and maybe in the beginning it was prescription opioids, but now it's evolved. I feel like the fear there. I'm hopeful that the public and that the policymakers and will get more involved, and that fear will subside a little bit, and we can kind of come back to our senses when it comes to this. I got a couple more questions here that I want to ask. I know that I don't see anybody who's raised their hand yet. I think this has been a great discussion so far. If anybody would like to ask a question, feel free to either unmute yourself. And if you can't find that hand emoji, but it's right where it says react on the bottom of your screen there. And feel free to ask a question if you like. Otherwise, I'll just continue. I got a few more questions here and then we'll wrap it up. The DEA cut the aggregate production again by 7% this year. We talked about that. It looks like they're going to be cutting the aggregate production of opioids again next year. We have seen, unfortunately, an inverse relationship between the number of overdose deaths, opioid-related overdose deaths, mind you, starting in 2012, and the number of opioid prescriptions that have been written and pills that have been written. So interestingly enough, the less opioids we write, the more people die. And yet the DEA is now once again going to lower the threshold for what can be produced and manufactured, even in light of the fact that we had massive shortages in 2023. When we talked a little bit about the pharmacists that say, "I'm just not filling the C2," oftentimes what they say we hear is that they just don't have it in stock. It tends to be a very good excuse just to, when you don't want to fill and you don't feel like having a frank conversation with somebody, is just say, "I don't have it in stock." How much of the supply chain is really an issue when it comes to having it in stock, and how much of that is just pharmacists that are not wanting to fill those prescriptions? And that was a two-part question. And then the second one is, how are you guys having those conversations with patients in a kind of a compassionate, and Mark, I know you well, and Robert, I know you well, and I know your organization well, and I know that matters to Advanced RX. I know it matters to you too, Mark, when it comes to having compassionate conversations with patients, understanding that they're already feeling stigmatized so much. Robert, how are you having that conversation with the patient? And Mark, I would like to know how you're doing that as well. And so 2 parts. Do we think there's an actual, is there really a shortage? Are you actually seeing that? Or is that just kind of blown out of proportion? And 2, how are you having the conversation? And generally, I see your hand raised. If you'll give them just time to answer this, we'll get to your question.
Absolutely. So, I do think, I think the shortage is being blown out of proportion. I do think those pharmacies have the prescriptions in stock, and they're just honestly just being overly cautious and not filling the prescription. It doesn't seem to be an issue from my standpoint. Seeing it on both sides of the supply chain. As far as having those conversations, those are tough conversations to have when if you don't have it, because then what it turns into from a pharmacy perspective is, right, it's our number one duty is patient care. That's why we're in this field. So if I don't have it, my job is to ensure that I either find that medication for the patient or reach out to the provider and potentially provide another therapeutic equivalent that could provide the same pain relief and benefit to the patient. So, those are typically the routes that I will go to try to find a pharmacy or talk to the provider. But, it's hard when you're talking about not having a medication that a patient's been taking for, if they've been taking it for years, and then all of a sudden what happens, you want to switch up something that they've relied on for their pain for years. They're not going to handle that well. I know I wouldn't. I wouldn't want to switch what's working because it's not broken. It's the system
Right.
that's broken.
I don't even want the blue one if you've been giving me the white one. And I am an experienced pharmacist. I mean, like, think about it. I digress. But as far as the supply things, it's been very well documented that there's been very specific prescription opioids that have not been available. But the headline has to say very specific opioids that haven't been available. It's not, there's no prescription opioids. On top of that, you have this conundrum, and there's been studies. I know some of the folks that have done them, and they did wonderful work, but it's an unsurmountable goal to say, is it stock or is it stigma? I just landed on those two words. There might be others. Um, of the old, I don't want to stock that or this or that. And then you have the dichotomy again of addiction and pain, different things. They can overlap, but different things there. Uh, all of that comes into play there. When quotas, federal level, you think about it. I mean, everybody here tonight and those watching in the future, I'd be willing, I'm not a gambler, I'd be willing to bet that you've seen some of the streamers, some of the documentaries, all the stuff about the pill mills, the opioid crisis, all of the stuff, right? Um, Even on my own podcast, I actually had the pharmacist. I'm just a pharmacist. I had the pharmacist on there, Dane Schneider, of course, from Netflix, bunch of other. We've seen those. That kind of stuff had to stop. I mean that's part of a major reason of why we're here having these types of conversations is because of such extremes in the past. That was not anywhere near clinical; it was criminal for the true, actual, tried and true in court pill mills. So that supply was not needed for legitimate medical purpose. That needed to be addressed. That, I keep saying that as a word, was not in 2023 necessarily, a while ago. But the trend keeps on going. So, the idea of like, oh, well, we're prescribing, dispensing less. And then it's this dichotomy of the illicit market and the healthcare supply chain, as we've been talking about at great length here tonight. It's very tricky. And those conversations, I think Robert already nailed it, you want to talk about, there's seminars out there on motivational interviewing. For the entire 8 hours, they could go over these kinds of conversations of how to go through talking through these things or emotional intelligence along the way as well too. So it's not easy. It takes time.
Yeah.
It takes that compassion too. So
Thank you both. Jenna Lee, would you mind go ahead and unmuting yourself and just tell us who you are real quick, and then feel free to ask your question.
Thank you so much. I work as a 1099 with AdvanceRx. I'm in Michigan. And I actually just have a
Great.
question. Robert, would you say if the doctor that was prescribing the C2 for the patient it took 5 days to get that prescription filled, if he would have put a non-control with it, do you think it would have been filled sooner?
That's a great question. Great question. Yes. Yes.
Did you typically put a non-control with a C2, like for your stomach or, anti?
So it all depends because I think when we're talking about pain, it is multifaceted. So, I mean, you have your first line therapies for pain that you always want to try first. So, depending on the patient's needs, and if the patient's been on it before, is it a recent injury? Is it something, if it's a recent injury, then yeah, I 100% would, okay, do they have an NSAID? Is there a need for a muscle relaxer? Is there something to that nature? Have they tried something that's not even maybe just a topical to see if they can use capsaicin? We have these first, second line therapies before we jump to what I like call the big guns. And I think if seeing that from a pharmacist perspective, you do feel more comfortable when you see other prescriptions other than just a C2, and not to say that Senna and Laxacin and the typical soul softeners like that, that's not going to make me feel more comfortable. That's going to make the patient feel more comfortable, but that's not really helping relieve the same thing that C2 is written for.
That makes sense. Because after I think it was the webinar that they were talking about how pain can be, emotional. It could be something that, you're depressed and just curious.
Yeah, absolutely.
Thank you, Jenna Lee. I appreciate that. CSJ's iPad. Go ahead and unmute yourself. Tell us who you are and ask the question.
Yes, Scotty Johnson with AdvanceRx. Robert and I have had numerous conversations about different things here. One of the things, I guess, to kind of piggyback off of Jenny Lee's question there, does a topical count as one of those non-controls in the ratio from that 3-to-1 side of things? And then with that, what do you do if you've got a state that doesn't have, they've got limits as far as being able to utilize on the topicals for their patient.
Great question. Great question. So yeah, you know, I'll jump in on here. This one, it's difficult because, you know, the topical does count, but from a compliance perspective, the topical medication isn't going to count how you think it would, right? So when we talk tablets and ratios and stuff like that, we're talking about the total number of tablets that patient's receiving. That's what the eyes look at and see. You know, that's what the DEA is going to see, the board's going to see. What they see in terms of a topical medication, they see it number one. They see you're getting 1 tube. They don't care if it's 99 grams, 999 grams. It's only going to count for 1. And so that makes it difficult from that perspective too, because it's not a true fair weight, but that's the weight that they you know, that the world's giving it right now.
Appreciate that question too. I think the topicals is a very good instance of bringing up how the concept of ratios, again, I kind of touched on a little bit, planting the seed earlier. The original intention was the whole picture. You know, what's being dispensed out of the pharmacy overall, not what is each patient walking away with or not, but the whole picture. And then that gets compounded, no pun intended, with you know, like what each person is there, because there is the other idea of, you know, Robert already articulated very well I'm like on the edge of my seat here. You can't tell if he's like, oh my gosh, there should be multifaceted, diverse pain management treatment plans. That's what I want for me and any family member. And an opioid is usually not going to be the first thing unless it's already hit the fan. There will be times for that. That'll be quoted someday, guarantee you. But anyway, but anyways, that we want that like that's the end goal, if there is one within pain management overall. So there's a very big confluence here. When you talk about things like topicals, I think that's a very interesting way of highlighting it, quite frankly. So.
Well, great, guys. We're just about out of time. I want to ask one more question just to kind of highlight what we discussed and kind of recap some things. And then, Robert, I'd love for you and Mark both to weigh in on something. This is just selfish, obviously, because I want to talk about our partnership with SureMed and Advanced RX. But from the conversation, it sounds to me like where we are right now and where we're headed is not very sustainable, especially given the fact that this new clearinghouse is going to be established next year, meaning there's going to be sharing data. You know, all 3 major wholesalers already have government-appointed monitors through this MDL injunctive suit terms. The clearinghouse will be sharing data. I can't see it where I can see that if one pharmacy ends up getting, you know, blocked from getting C2s, that, you know, the other wholesalers are going to join suit, right? That's going to be pretty risky. It sounds like that they're probably not, you know, we could legitimately find ourselves in a situation with a lack of pharmacy services is what it feels like, because we're already watched Walgreens shut down. I don't know how many, you know, 1,000 stores they shut down recently across the country. And you've got all the major retail chains now that are scrambling, including the independents, to try and meet these injunctive terms. Robert, talk a little bit about our partnership, if you would, why that's important. We did talk about how data, and when there's a lack of data, people have to be very conservative and have to use only the data that's available. Maybe talk a little bit about, and Mark, you know this well because you and I worked together on that team to even develop what we're doing now with Advanced RX. But go ahead, Robert.
Yeah, absolutely. I mean, and this is really what I was talking about earlier with that, you know, that open communication, right? I mean, we talked about, even Mark mentioned, hey, try to call the doctor's office and see if you get a hold of somebody. Call yourself and see if you get a hold. And it delays care, delays treatment. You know, the great thing about our partnership is that, you know, we're given that legitimate medical purpose. Everything that we talked about today during this discussion is really, it hones into what the communication tool is providing to the pharmacy and allows us to know that the patient has a purpose for it. All these other points have been checked. Everything I would want to see being checked is there. And then also having access to that so that I don't have to call, I don't have to question. I don't have to put on my blinders and say, okay, you're just every other patient coming my door. No, you're not. your patient, and I can see those, you know, what was done and know exactly what happened in that office visit. And I feel a lot more comfortable doing that. And providing that patient the medication at that point, that I there you go, that paper, right in the profile. I can review that. I feel good. It's
That's
really
great. Thank you, Robert.
Yeah.
Thank you.
Yeah,
Mark?
to what we've been talking about it's you know, it's all about the communication and time to do that along the way. Gosh, John, I remember the first conversations we ever had when you were, you know, explaining, hey, what are you guys up to? And I'm like, oh my gosh, we're finally going to no longer practice. I am not an MD or a DO. We're not going to practice medicine. We're actually going to provide patient care. Like we're going to deliver medicine. It's get rid of all the ins and outs, the fluffs, the speed bumps, the barriers, the concrete walls. Replace it with information. You can't make an informed decision without information. It's the most basic thing on this planet, other than oxygen. It's just that's a lot of what we talked about tonight was the communication and getting that information, and then it's also what you do with it. You know, to all of our pharmacy colleagues out there, what's the limit for documentation within any pharmacy system? And I'm getting a little wild here saying any, but at least the top 10 dispensing systems, right? Is the character limit more or less than Twitter? My apologies, X. Like how much space do you have? Like a little more than one letter X, right? It's and that's what you're retaining, let alone what you're receiving. And then what if you receive more? What do you do with it then? You know, it's very tricky. We want our cake and eat it too as clinicians because that's what our patients deserve. And anything that helps with that, there we go.
That's great. Everyone, I want to thank everyone for attending. We went a little over time. I just want to see if anybody does have any other questions, please raise your hand and we can answer those certainly. If I don't see those hands go quickly, though, we'll go ahead and get done. I do want to thank our panel speakers today. Thank you to Dr. Mark Garofoli. Thank you so much to Dr. Robert Bird of Advanced RX. And thank you to all of our guests. Again, this was sponsored by Advanced RX, which is a proud partner of SureMed Compliance. If you are interested in learning more about Advanced RX services, they are a full service pharmacy management services provider. They work not only with just physicians that heavily are in the work comp space, but they work with pain management physicians, orthopeds, really all different types of specialties all over the country. And they're doing things the right way. They're doing things working hand in hand with SureMed Compliance to ensure that everything that they do is sustainable and make sure that ensures that the patient gets the care that they need in a timely fashion. So we want to thank them for sponsoring this. Again, thank you for everybody. We will make this available online through our website as well as social media here within the next coming week. Everyone have a great night.
Thanks for having us, John.